joining us. I'm Jennifer Sizemore. I'm the Chief Communications Officer for the Southern Nevada Health District. I want to recognize some special guests that we have here with us today, in no particular order. We have Assemblywoman Monroe Moreno. Assemblyman Brian Hibbets. Assemblyman C.H. Miller. Assemblywoman Chandra Summers Armstrong. Assemblywoman Tracy Brown May. Assemblywoman Danielle Gallant. Thank you for joining us. And I also want to recognize two of our board members that are here today. We have Dr. Hardy, Mayor Hardy. Is he still here? Oh, I'm sorry. Councilman Black.
Let me get out of the front row.
And with that, I will ask Dr. Legend to come up.
Thank you. Well, good afternoon, and thank you for being here. We really appreciate your presence here, and more than anything, your commitment to this community. First, I want to say that my name is Fermin Legend. I'm the head officer for the Southern Nevada Health District. As you know, this week is National Public Health Week. And this is a week dedicated to recognizing public health across the country and also highlighting the important public health issues that are affecting our community. This year we will be presenting to you two important issues that are impacting our community. And when I say impacting, is impacting in a very negative way. We will be talking about congenital syphilis, which is a condition that is fully preventable. And it's a condition that is affecting many families across the country and also our community. And also, we will be talking about substance use, harm reduction, and overdose burden in Southern Nevada. Today we will have first a presentation from our health district team. Actually, they are our investigators, Carissa, Angel, and I missed you. Tabby. Sorry, apologies for that. I should know everybody's name, but that's my mistake. We have grown so much in the last 4 years. Right now, we are over 800 employees here at the health district. Pre-pandemic, we used to be about close to 500 people, so there is exponential growth here. Which again, so we'll be talking about congenital syphilis first, and then there will be a panel that will be addressing issues related with overdose and harm reduction. Once again, I really want to thank you for being here. We are very, very impressed. For us, having so many representatives of our community here, especially from our state legislature and also representatives from local government here in Southern Nevada. All of you are huge contributors to what we're trying to achieve every single day. And we really appreciate all your help, and we still are looking for even more help from you. So thank you.
Tabby Edelman, and we're going to talk about congenital syphilis. First, let's start with what syphilis is. So syphilis is a sexually transmitted disease. It's a bacterial infection, and it is treated with antibiotics. Now, congenital syphilis happens whenever a pregnant person with syphilis passes that infection along to the baby. Now, this is completely preventable. That was not preventable. Oh, there we go. So as I was saying, congenital syphilis is completely preventable, but yet it still impacts our community greatly. As you can see, there's a long list. Thank you. Thanks so much. There's a long list of symptoms that these babies can exhibit. Mercury's in retrograde. Thank you. So there's a lot of these symptoms that these babies can exhibit if they do have congenital syphilis, and that's if they are lucky enough to be born. Unfortunately, in just last year in 2023, we had 6 syphilitic stillbirths. I'm going to pass it on to Angel so they can talk a little bit more about our congenital syphilis rates here in Clark County.
Good afternoon. I'm Angel Stashik. I'm a senior epidemiologist, and my area is in HIV and STD. So I just wanted to go over a few slides about syphilis. So before we go into congenital syphilis, I want to talk about syphilis rates overall. And the slide you're looking at here is broken down by the birth sex. So it's the sex assigned at birth. And so you can see here, the green line over here is representing the overall rate. So that includes both genders. And typically this rate is driven by the male rate, as you can see here depicted in blue line, because we do have higher rates of syphilis in the male. So let's take a look at the blue line here. So we can see here from 2014 to 2017, we see the rate kind of climbing up pretty steadily. We had a pretty good increase. So, okay, much better, right? So, 2. Okay, so again, this is syphilis, infectious syphilis. Oh, so before I go into the rates, so infectious syphilis is a group of syphilis. So we have primary syphilis, secondary syphilis, and early syphilis, non-primary, non-secondary. And these are different stages depending on the symptoms that they show. But basically they're grouped as infectious syphilis because they're recently acquired, meaning they're infections that are new within 12 months. So we do diagnose syphilis when people come in really late after 12 months of their infection, and they get classified as late or unknown duration. So this graph is depicting infectious syphilis. And so again, going back to the blue line, we can see here from 2014 to 2017, we do see the steady rates of increasing among males. And we do see a little bit of stabilizing going on here from 2017 to 2019, and then it kind of like shoots up from 2020 to 2021. And this is most likely because of the pandemic shutdown. People were holding off on testing, so we kind of see it shoot up, and then we start to see a little bit of decreasing trend here from 2021 to 2023. Now let's focus on the females. We see a little bit of different story with the female syphilis among females. And you can see it didn't matter throughout the year, aside from 2022 to 2023, we see a steady increase. So in 2014, we had about 6 cases in about 100,000 female population. And by 2022, it's up to about 28 per 100,000 females. And then we see a little bit of decline in 2023. But so whenever we see an increase, we're seeing an increase in the males, but whenever we see an increase in females, we see congenital syphilis go up. And so, as you can see here, going up, so we have showing in the blue bars, this is the actually number of cases we had in the past 10 years, and then the rate that's depicted in the orange line, which is depicted by congenital syphilis cases per 10,000 live births. So as you can see here in the blue line, so in 2014, we just had 3 cases. That's more than we should have, but it was 3. And then we go to 2023, we have 53 cases. It's a lot of cases. And then we go looking even at the rates. So I had to suppress the the rates for 2014 to 2016 because they're unreliable because of the case count being lowered in 12. But as you can see here in 2017, it was about 7 cases per 10,000 live births, and we have increased to about 22 cases per 10,000 live births in 2023. So it is a huge increase that we have had in the past 10 years. And so there's a lot to be done in forms of prevention. And just to kind of give you an idea, so in 2022, which was the national data, the latest national data given, so Nevada ranked number 8 in terms of congenital syphilis. Nevada came in about 19 cases per 10,000 live births. And then for the US, it was about 10 cases per 10,000 births. So, we ranked number 8. In 2021, we were number 9. Prior to that, we were number 4. So we are doing better in terms of rates and rankings, but as you can see here, our rates are increasing, our case numbers are increasing. The only reason why our rankings lowered is because the other states are increasing as well. So, and now I'm going to turn it back to you, Tabby.
Disease investigation and intervention specialists. They play a significant role whenever it comes to preventing congenital syphilis. So DIS for short. DIS are found all over the world investigating different types of disease like STDs or Ebola, Zika, foodborne illnesses. DIS, what their main role is to intervene and stop the spread of disease throughout the community. They do this by ensuring that folks are getting their treatment. Any people who may have been exposed to that disease, we want to make sure that they're tested and that they're offered preventative treatment if that might be the case. And a lot of times, because we are so busy trying to keep our community safe, we're not able to offer that intensive case management service that some of our folks may need. And so we do often send out community referrals to our partners for social services and behavioral health services and substance abuse treatment. In regards to congenital syphilis prevention in DIS, anytime that DIS has a pregnant person on their caseload, they are going to passively follow that client until delivery. This allows the DIS to monitor any testing that they may have between treatment and delivery. Also, making sure that their partners are tested and preventatively treated as well. If you notice, third trimester titer is on this list. It's very imperative that pregnant people get this syphilis testing in the third trimester, especially if they haven't been tested yet during their pregnancy. This lets us know where they are at as far as needing to get treatment, or if they have history, if the treatment in the past has worked. And it also, this third trimester testing, it really helps us kind of, it's always me that this happens to. So it's very important that these women are tested during the third trimester because this lets us know, if the treatment has worked or if she's been reinfected. Also, any treatment done before the third trimester, it really helps kind of limit the risk to that baby contracting congenital syphilis. As I mentioned before, we make a lot of referrals to our community partners for that intensive case management portion. And a lot of times we actually make our in-house referrals to our nurse case management program here. So I'm going to turn it over to Carissa so she can tell us about all the great work that they're doing in the congenital syphilis nurse case management program.
everyone. My name is Carissa, and I'm one of the nurses for our congenital syphilis case management program. So today, I'm going to highlight the importance of why we need this program. From 2014 to 2022, congenital syphilis cases have risen 1,567%. We're going to take a closer look as to what happened in 2022. Symptomatic, meaning they had no symptoms at all. 66% of those CS cases were drop-in deliveries, and 63% of the mothers had no prenatal care at all during their pregnancy. Also, 59% of the mothers of CS cases had a positive toxicology screening. This just goes to show our cases aren't just pregnant people dealing with syphilis. We're caring for patients with additional comorbidities. Our eligibility requirements are simple. Our patient needs to be pregnant and diagnosed with syphilis, and staging isn't a factor. We can enroll the patients up to 6 weeks postpartum. As a nurse case manager, some of my daily activities include academic detailing to OB providers and nursing staff at our local hospitals. We emphasize the importance of AB 192 to make sure that our pregnant people are getting tested during pregnancy and at delivery. Also, I help navigate and increase access to care for mom and baby. As mentioned earlier, 63% of the cases had no prenatal care, so it's imperative that we provide that linkage. Lastly, we provide referrals that are made to community partners for adequate care and treatment. Some of these referrals include Nurse Family Partnership, WIC, Track B, and a few others. Unfortunately, some of the challenges we face include caring for our unhoused population. It can be difficult to track them and engage them in care. Also, navigating the bus system can be challenging for our patients, especially in those summer and winter months. In addition to that, our clients are reluctant to engage with our healthcare system. They're embarrassed to be seen at our clinics. Lastly, testing should be performed on all deliveries, and unfortunately, that's not happening. Our next steps as an agency is to expand our HATS program. It's short for Home Administered Treatment for Syphilis. Our goal is to provide street medicine and meet clients where they're at. This is going to help us eliminate any barriers our patients have coming to our clinic. I'm going to hand it over to Tabby to finish this part.
So something else that we're doing to prevent congenital syphilis is that we've created a statewide congenital syphilis review board. Quarterly, a group of folks, a multidisciplinary team, gets together and we review previous cases of congenital syphilis. If you can imagine any type of person who is offering a service to a pregnant person, like social services, providers, substance use treatment programs. These folks are coming to this meeting and we're talking about these congenital syphilis cases, trying to find missed opportunities for prevention. And we don't just stop there. After we find the missed opportunities for prevention, we try to find creative ways to tackle those issues and to come up with solutions. And I'm going to turn it back over to Carissa so that she can talk a little bit more about the missed opportunities and the possible solutions that we come up with just this last year.
So as Tabby mentioned, I will be reviewing some of the missed opportunities. The first thing I'd like to talk about is access to healthcare. Our patients do not have insurance, a majority of them don't, and they don't know how to attain these resources. The goal should be meeting our clients where they're at. We need more outreach events. What comes to mind is having several community partners and social services coming together to have like a one-stop shop for these patients. Also, provider knowledge. There's a lot of missed opportunity for STI testing, and there's still a misunderstanding about treatment for syphilis with primary providers. Again, that's why we highlight our academic detailing, and that's why it's so important that we go out there, as we are, and making sure providers know about SB 211, where they're allowed to offer STI testing for patients 15 years or older, in addition to SB 192 to make sure that all pregnant people are getting tested throughout their pregnancy. Also, we would like to have sexual health questionnaires and trauma-informed care in medical schools or in continuing education credits for providers. Next, individual knowledge. There's still a lack of awareness about STIs, and patients have a low perceived risk for these things. I still have patients tell me that they contracted syphilis from a toilet. And to me, that means we need to improve our health literacy and on our educational material, and have age-appropriate sex education in schools and leverage social media. A lot of people are getting their information from there, and we should utilize that. In addition to that, we have some social factors where a lot of patients I see are single mothers, are in a domestic violence relationship, are involved in the justice system, and have a loss of confidence with our U.S. healthcare system. It's important that we communicate and let the clients know that we have all these resources and social services that can help them. Again, let's leverage social media and meet those clients where they're at. Also, substance use and mental health. It's important that we improve overall access. We need to address the stigma and let our patients know we're there for them so they feel like they're comfortable coming and having these conversations with us. Lastly, unplanned pregnancy, contraception, and sex work. Again, we need age-appropriate sex ed in schools and occupational health and safety for sex workers. So I leave you all with this. Sexual health matters. It's important we have these conversations. I know they're uncomfortable, patients are uncomfortable, providers are uncomfortable, but we need them so we can make sure our patients are safe and our community is healthy. Thank you. Marco, I think it's you.
Excuse me while I mic up for a second. I'm going to be up here for a minute. So, thank you to our presenters who just went and educated us about sort of what's going on with congenital syphilis here in our community. I am here today to speak about our overdose burden in Clark County. As we know, it's an issue that comes up regularly in the news, and it's something that we definitely should keep an eye on and continue to reduce through our prevention activities community-wide. So to begin, I just have a slide here showing our overdose rates, with the top line showing the combined rate for intentional and unintentional overdoses, the middle line showing unintentional overdose rates, and the bottom line in yellow showing intentional overdose. The takeaway from this is that most of these overdoses are unintentional, so it is important that we continue to educate our community on safer practices as far as prevention. Something else I'd like to point out is looking at our unintentional rates. So from 2020, we had a rate of 22.73, an increase in 21 to 24.08 per 100,000, slight decrease in 2022 to 22.86, and then another slight decrease to 20.71 per 100,000 in 2023. However, it's important to note that while we may be seeing a decrease, we are still above our pre-pandemic levels of overdose, and that's important to keep in mind. On this chart here, we can see overdose rates per 100,000 population by drug class. So the top line in black is inclusive of all drug classes, while the second line in the light blue shade encompasses all opioids. A few data points that I'd like to point out are that in 2020, we started to see an increase in our overdose rate for synthetic opioids. So this can include fentanyl, its analogs, and similar drugs. And then by 2023, our rate of overdose among synthetic drugs has also caught up, our rate among overdoses with psychostimulant drugs has caught up to our rate of overdose among synthetics. So psychostimulants can include anything mind altering. This can include methamphetamine and drugs of that sort of class. So these are at 11.49 per 100,000 population as of 2023. Although we have seen decreases since 2020 in our prescription opioid, benzodiazepine, and heroin overdose rates. So we definitely need to keep an eye out on our psychostimulants as well as fentanyl, of course. Among drug overdose deaths, and this is just for 2023, these are provisional estimates, but you can see here the different drug classes and then the percentage of deaths in which each class was implicated. These aren't mutually exclusive, so they will not add up to 100% exactly. But what I'd like to point out is that fentanyl was implicated in 51.5% of these overdose deaths just in 2023. But another issue we're facing as we confront overdose burden is drug contamination within the supply. So again, for 2023, these are drug classes that were implicated among fentanyl overdoses. So in addition to fentanyl, we did see psychostimulants present in 46.4 of those fentanyl overdose deaths. Now to sort of give a little bit more context as we begin 2024, I have some zip code maps. On the left, you'll see, on this slide, on the left, we'll see Clark County, the Las Vegas metro area, excuse me, and on the right side, we have all of Clark County, so this would include Boulder City, Mesquite, and Laughlin. This is in 2016. As you can see in this yellow shade, these represent 0 to 4 overdose deaths per zip code. 2017, we had relative stability. 2018, we continued to see relative stability in these overdose death rates, or overdose death counts, excuse me, as well as 2019. So leading up to pandemic times, of course, when treatment was more inaccessible than it was prior, we do see our first set of increases in zip codes within Clark County. And this continues to spread in 2021. The darker shades indicate higher death counts, or yes, higher death counts. And then in 2022, we see continued spread and increase in zip codes where the burden was already present. So, takeaway I would like for you to have as the community to keep in mind is that while we have seen this decrease in the past few years in overdose deaths, these colors, counts, rates, they all represent individual lives that we've lost within our community. So prevention efforts are definitely a good way for us to move forward in preventing more of these deaths. And with that information in mind, I'd like to turn it over to Victoria Burris for our Substance Use Resources and Prevention panel.
So good afternoon, everyone. I want to thank you all. I want to thank you all for joining us today. My name is Victoria Burris, and I'm the Communicable Disease Manager for the Office of Disease Surveillance in the Division of Disease Surveillance and Control. I am honored to be facilitating our panel discussion addressing the overdose burden in Clark County, and I want to express my sincere gratitude and appreciation to our panelists who are joining us here today. This is a community-wide issue, and we are all here today because we want to work together to prevent overdose-related deaths. Each of our participants brings a wealth of knowledge and expertise today, and I know we are all looking forward to the discussion. So I'd like to start off with introductions. Joining us today, we have Victoria Hughes. Victoria is a communicable disease supervisor here at the Southern Nevada Health District. She has been in the public health field for more than 11 years, where she started her journey as a syphilis, HIV, and tuberculosis disease investigator. Currently, Victoria oversees our Linkage to Action team, and the mission of this team is to combat the overdose epidemic by offering harm reduction and linkage to care services for people facing incarceration and other vulnerable populations. Welcome, Vicki. Next, we have Dr. Terry Kearns, who is currently serving as the statewide substance use law enforcement coordinator in the Office of the Attorney General. Dr. Kearns has been a nurse and special agent with the Federal Bureau of Investigation, where she worked in programs ranging from healthcare fraud to weapons of mass destruction and terrorism investigations. In her current position, Dr. Kearns blends her background, experience, and education to emphasize a holistic, multidisciplinary approach focused on law enforcement, healthcare, and public health professionals. And the primary focus of her position is to address the opioid crisis here in Nevada. Welcome, Dr. Kearns. Next, we have Kat Reich, who is the Senior Administration and Data Manager for Track B Exchange. Kat is passionate about her work to ensure innovative harm reduction methods are an integrated part of community health and empowering people to make informed choices in their harm reduction strategies. Track B is dedicated to improving the quality of life for those affected by substance use disorders and was the first organization in the continental United States to implement harm reduction vending machines. Track B provides harm reduction services, supplies, counseling, and a range of other programs through vending machines, storefronts, peer programs, and more. Welcome, Kat. And finally, last but certainly not least, we have Assemblywoman Clara Thomas, who began serving in our Nevada Assembly in 2021 and is an active member of SURGE. SURGE is the Substance Use Response Working Group. SURGE was created during the 2021 legislative session by Assembly Bill 374 within the Attorney General's office. The group develops recommendations to improve Nevada's substance use prevention and response efforts. During her time in the legislature, Assemblywoman Thomas has supported issues related to public health, healthcare, and social services. Please join me in welcoming all of our panel members today. Okay, so let's move on to our first question, which I'll pose to our full panel, starting with Dr. Kearns. Why is fentanyl, as well as other synthetic opioids and fentanyl analogs, a bigger problem now than in the past? Based on the data that Marco just presented to us, we're seeing an increase in the use of these substances, as well as an increase in their contribution to overdose and deaths. Dr. Kearns, please share your thoughts and insights on this.
Thank you for the opportunity to address this question. As was presented to us already, the drug supply is tainted. So often people will have drugs and think they're taking one drug, but they're also getting fentanyl. It's as evidence from our crime labs, many of the drugs that they are testing are tainted with fentanyl. And people will seek a drug and not even know that they're getting fentanyl. And especially if it's someone who's opiate naive, they will suffer the consequences and potentially overdose from that fentanyl and not even know that they have taken it. So along those lines, we really need to educate our population on the ability to A, test their drugs, B, have opiate antagonists available, and not to take drugs alone so that someone will be there to revive them should they need it. One of the other things that is also has been noted is that the age of people that have overdosed from fentanyl is getting younger and younger. So, and again, children are getting drugs sometimes through social media, through friends, those sorts of things, thinking they're getting a prescription grade drug, and it's not that at all. It's a fake pill that does have fentanyl in it. So it's a multifaceted problem that we need to look at from many different ways in order to address the issue.
Thank you, Dr. Kearns. Assemblywoman Thomas, Kat, or Victoria, please share your insights.
So the seeds of the current fentanyl crisis were really planted during that first wave of the opioid epidemic that we saw in the late 90s, early 2000s, when we saw an uptick in the availability of highly addictive prescription opioids that were being diverted for recreational use. When plans were put in place to prevent diversion, people unfortunately turned to illicitly manufactured opioids like heroin. And so this demand in heroin then created an environment where the people that are creating the opioids turn to fentanyl because it's a fully synthetic opioid. You don't need a poppy plant like when you're making heroin. It's really cheap to make. It's extremely strong, so a tiny amount of fentanyl can create the same effect as a larger amount of heroin, and it's highly, highly addictive. And as Dr. Kearns had mentioned, what we're seeing is people who think that they're only using cocaine, for example, or think they're only using other stimulants like methamphetamine are overdosing because of the adulterated drug supply. Thank you.
So one of the things that we've been experiencing when we discuss things with our participants in terms of what they're seeing or expecting in their drug supply as injection drug users which is very, very dangerous for the mentality of their approach to their drug use, is that we're starting to see an almost fatalistic expectation that fentanyl is in everything. And we're seeing that for people that are capable of testing their products and could be veering away from it, that instead they are just assuming that it's there and that it's not worth testing for anymore. And that is dangerous for them. But then we also have other people who think that their drugs are completely safe because they're not injecting them. And like it's kind of already been iterated, things like psychoactive substances, things that are not meth or heroin, people aren't testing for those still. They don't understand that those are laced and that they're in danger because they're not receiving the proper education of knowing how to test for those products. And that is definitely leaning people towards this almost, it's not so much lack of concern, but lack of expectation that they're going to survive long term with their substance use because they pretty much just assume that one day it's going to get them. Thank you.
Thank you, and thank you for the question. I think that from being on the committee and being on the committee for treatment and recovery, what I've come to find out, it's really, we have to blame, if we have to blame anyone, is the drug companies. Because one, it was introduced to us as being safe. Our doctors were prescribing it, and it was something that I think once it got onto the streets, we looked at it as being different from methamphetamine. And it was, told to, and this is during social media and things like that, that it's safer than meth. And I think that when we look at our drug companies that promoted this, I think that this is something that our AG office went after because it wasn't. The fact that it's a safe drug, it is not safe. And I think that we are looking at it as different than just putting it as far as people using drugs. I think that we have to look at the core, we have to look at the foundation, we have to look at who prescribed it and how it got on the streets.
Thank Thank you all. I appreciate all of that insight. We'll move on to the next question. Now, the data are showing us that the COVID-19 pandemic exacerbated the trends we've been seeing. The pandemic increased social isolation, stress, and reduced access to care for many people. I'd like to start with Assemblywoman Thomas. What are your thoughts about the relationship between the COVID-19 pandemic, health disparities, substance use, and recovery services?
I'm going to say something that most people probably have thought about, but I think COVID opened up a lot of insight to a lot of holes in our society. And I think that with the pandemic, we had time to reflect, we had time to not so much see our doctors, we had time to experiment, and our children especially experiment in drugs. And they would experiment to the point that they overdosed, and our children as young as 8-year-olds died. So COVID exposed a lot of societal things that we have dismissed as being normal, and it's not normal for our kids to take drugs, and when we are faced with isolation, and we are social people, and during COVID we were isolated, and with that we found out self-reflection, and our kids were self-reflecting, and they were looking at themselves as not being acceptable in society because something must be wrong with them. And with that, they chose to self-medicate. And I think that COVID showed us as adults that this is something that we actually have to look at as far as our children are concerned, because they are lost. And if we don't do something about that, we have a society that is lost. We will miss a group of people in the society that are not here with us today if we continue on the avenue that we have been. We have to face it. And COVID actually exposed what was going on.
Thank you. Would any of our other panelists like to weigh in?
Sure, I'll add to that. Along with what Assemblywoman Thomas was saying is, I think as a state and as Clark County, we did a really good job of getting opiate antagonists such as naloxone to the people who needed it. However, during COVID, based on data that was presented from the state's overdose data to action, we saw a shift in where overdoses were occurring. So that shift was now that people were overdosing in their homes, often alone, and as I previously said, that goes against the tenets of harm reduction that are often discussed with people who use drugs. So people were taking drugs by themselves, getting drugs that maybe they weren't as familiar with the sources of where they came from, so getting fentanyl, getting drugs that were tainted, that they didn't realize were tainted. So we did see that shift in a lot more of the overdoses occurring in the home as opposed to out on the streets, for example. So that was one thing. And another thing is that if there was any good that came out of COVID in terms of substance use and probably some other areas that were discussed, is that we did see some changes in our DEA X waiver. The DEA X waiver, for those who don't know, is what a provider has to have in order to be able to provide substance use treatment to someone. So unfortunately, we haven't seen a huge amount of the providers actually using that. So that's something we need to do, is to get providers to start using the capability to now require less of that training, but just safely. They provide some of these drugs for pain management, but are not providing them for substance use. And the other thing that we saw that has continued to stay today is the use of virtual access for telemedicine and telehealth, which has really been able to increase our outreach to those people who didn't have access for substance use treatment previously.
Thank you. Appreciate that. Did you want to share something?
Yeah. So we definitely talked a lot about how we've had an increase in the number of overdose during that period of time, but we also had a significant increase in the amount of use during that time. That's a little bit harder for people to track unless you're seeing someone either have an overdose or get arrested for it. But as a syringe exchange, we saw such a rapid increase in need for our services during that year that we could barely keep up. We were one of the agencies that was open during shutdowns, and we quite literally multiple times throughout that year were running out of supplies because we had such an increase in demand for our services from the previous year. So definitely COVID increased people's uses in general.
Thank you. So in February, the Health District issued a news release urging heightened awareness of the dangers of mixing stimulants with highly potent synthetic opioids. And Marco, you touched on this in your presentation, but between 2020 and 2023, the number of overdose deaths among Clark County residents involving the concurrent use of fentanyl with methamphetamines or cocaine increased 97%, from 73 deaths to 144 deaths. Victoria, I'd like to start with you. Are the current treatment options and resources available for our community appropriate or adequate when you think about this concurrent use?
Well, I think across the board, Clark County has some barriers to adequate access to care regardless of the condition. That does translate to substance use disorder as well. But I will say here at SNHD, we and our community partners have tried to at least increase access to low barrier harm reduction services. So we have a pretty robust fentanyl test strip distribution programs. Shout out to Kat Culver in the back there. We have a countywide naloxone distribution program. We also have a team of individuals who are co-located at the detention center who offer linkage to care services to people who are currently facing incarceration. And we try to work with community partners to have tailored outreaches where we look at that overdose data. We look at some of those health disparities, and we try to target our outreach and our intervention activities to meet the needs of people where they are.
Thank you. Did you want to weigh in?
Thank you for that. So we do definitely see, as an agency who's trying to get people into more positive outcomes over the time that they come in to see us, and building that rapport with people so that we can help move them towards a direction that's better for their own personal health and the community. There are still significant barriers to moving them in those positive directions, especially not having enough beds for inpatient treatment in the community compared to the number of people that are interested in receiving a bed, and also that we typically run into an issue with people being able to admit themselves into those locations. They almost always require some sort of referral from another agency, such as ours, to be able to be taken seriously as to whether or not they actually wish to go into treatment and try and find a way to move away from substance abuse.
I think I expressed that sitting on a committee that's for treatment and recovery, one thing that my committee zeroed in on was the fact that our children right now, the ones that need care, are actually sent out of state. And as a parent, I think that is something that we have to look at in the state of Nevada, that our children are suffering, and parents cannot afford to send our children out of state for recovery. And I think this is one of the issues that me right now speaking to this body, that this is something that is very, very important for us to look at, because most parents will not send their children out of state, whether or not it's up in Utah or across country to Georgia. You know, and we have children that, as I said, as young as 8 years old, that are affected by this drug. And I think that we can say all day we need more beds, but we have to do it. We have to provide it. We have to make it a point of getting these beds, getting the facilities open for our children, if nothing else. This is very, very important.
Thank you.
Can I just add, I'd like to say that I think as a state and as Clark County, we have looked at some innovative ways to try to reduce the burden on the treatment providers that we do have. I know, for example, Dr. Kelly Morgan is trying to work on an emergency department bridge program. And what that means is that if someone comes in with a suspected overdose, that they could, in the emergency department, start substance use treatment for that person with medication-assisted treatment, because oftentimes a bed isn't available. So it's a bridge to get them started, and then they could provide a couple of doses until that person can get into treatment. So I think we really need to expand programs such as the Bridge program, and also not so much here in Las Vegas, but more in our rural areas, both in Clark County and throughout the state, the use of some paraprofessionals to extend the outreach of peer recovery support specialists and community health workers. And they don't take the place of those behavioral health professionals, but they work under the direction and provide more outreach and ability to get to those people who can't be here and get to the substance use treatment facilities.
Thank you. Appreciate that. So moving on to the next question. In Southern Nevada, we have been innovative in our harm reduction strategies, from launching the first in the nation impact exchange vending machines that include syringes, naloxone, sharps, containers, and more. Kat, as a representative of a direct service provider, are there any policy changes that are needed to allow us to better serve our communities and provide even more enhanced services?
Yes. So what we would feel is going to be the most impactful to widening the population in Clark County that we can actually be helping would be to continue the process of decriminalizing certain materials and paraphernalia that currently, if someone were to be in possession of, would still get them into very big trouble, especially related to safe smoking and smoking supplies. The reason for that is that those supplies, if you don't have something safe to use, can still be incredibly damaging to that person's body. It can still lead to infections. It may not be bloodborne infections, but it can still lead to infections. It can still lead to lung problems, and it can still also lead to transmission of disease, because if they have wounds on their mouths, and they're sharing supplies, that can still transmit things. And by having that be decriminalized and allowing agencies to be able to supply them with those, that increases the likelihood that they're going to be engaging with agencies that are then going to be able to continue helping them move towards those paths of harm reduction and increasing their positive outcomes. And without that, we're going to continue to see a shift away from injection use towards those as a potential safer way of avoiding fentanyl overdose by going slower and using alternative methods. And eventually we're going to have a huge portion of the population that never engages with harm reduction services as they currently exist. And that's a huge group of people that are then a missed opportunity for being able to help.
Thank you, Kat. Would anyone else like to weigh in?
So to add on what Dr. Kearns had said about the peers, we know that having peers and people with lived experience is a proven method of engaging people who use drugs to supportive services. But one challenges we see are, even if someone is able to pass the certification test, trying to get internship hours has been a barrier. Trying to get onboarded with an employer has been a barrier because there are policies in place that prevent people who have been justice involved in the past from getting employed in certain places. So I think if we were to help employers with recruiting, retaining, and supporting people in recovery and doing this work, we would have a lot of a stronger workforce.
I was just going to add.
I was going to say decriminalization is probably the best method right now, because we have so many people that are using, and when they, they're not we're going after the wrong people. That's, that is what I want to say. We're actually not going after the drug suppliers. We're not going after the ones that are the criminals. We are going after the low-hanging fruit, so to speak.
And just to add, I would like to say that one of the things, I'm also on the surge with Assemblywoman Thomas, but on the response subcommittee, and one of the topics that we've struggled with is there's a conflict in our state between our Good Samaritan Drug Overdose Act and the drug-induced homicide. And we often hear that people know under the Good Samaritan law that they can call 911 and not be arrested for the drug use with that person, but they're afraid to call because they're afraid they're going to be arrested. And also, it's recently come to my attention that they're afraid to call also because of what we're now seeing as compassionate care to that person. So our law enforcement have become really good about carrying not the naloxone, mostly it's the nasal spray, 2 to 4 milligrams, and EMS as well has naloxone available to them. However, in a recent webinar that I was part of in Europe, our 2 to 4 dose is considered high dose. So that will often put someone into withdrawal. So people are afraid to call because they don't want to go into withdrawal. It can be a life-threatening condition. So that's one of the things. And the other thing I just wanted to hit on is I know that we are doing a better job with the people who are in our carceral facilities and trying to get them the resources. But we are also looking at the 1115 Medicaid waiver so that people can get Medicaid up to 90 days before they leave a carceral facility so that their care would continue and there wouldn't be a gap in that care. So something that DHHS is working on, but I advocate that we have legislation in our state to really push getting that 1115 waiver.
Thank you. So, lastly,
She had one more thing.
oh, I'm sorry, go ahead.
So the last thing I had to add to that, it's not exactly a policy change, but maybe more of an acknowledgement that there is still a very strong issue of stigma with prescription use. And that does, we know that does lead towards the possibility of switching over from prescription opiates to illegal opiates. And we've done a lot to try and mitigate the damage of the prescription problem with opiates and pain management. But now we have kind of the opposite problem, which is that the restrictions have become so tight and there's still such a strong assumption amongst providers that if someone needs something because they have a physical dependence on it, that they are a drug abuser and that they have no issue with trying to go around the system and be a bad person who's just an addict. There's still a strong assumption of that. And if we don't try and educate and kind of address that situation with providers, we're going to potentially still see the possibility moving forward that people will switch from prescription opiate use to heroin or fentanyl as the only way of being able to manage their health. They're not doing that because they are an addict, they're doing that because they have been given this physical dependence and they quite literally need that drug to be able to function.
Thank you. Thank you for that important point. So lastly, I wanted to pose this last question to all of you. How do we continue to make strides in prevention, awareness, and treatment as it relates to substance use and overdose? And who is not included at the table that should be? Dr. Kearns, would you like to start?
Sure. My first thought on this is what Kat finished with, and that I believe stigma is one of the major issues that we deal with. And that why are we looking at substance use disorder any different than we look at cardiac disease or diabetes or anything else? It is a medical condition, and we should be able to treat it as such. So I would hope we continue to work on that stigma. I also would say that although the community has done a great job in getting opiate antagonists such as naloxone out to the community, I'd advocate, just like we have automated external defibrillators in public places, that right next to those, we have like they call them nalox boxes where people could get naloxone available. And then one of the last things that I would advocate for is better near real-time data sharing. And when I came into this position, what I thought the definition of real time was different than depending on who you talk to. And when I talk about near real time data sharing, it's 24 to 72 hours. Because if we wait weeks to months to get toxology reports and those sorts of things, whatever was affecting in our drug supply at that time is done. So we can't take any actionable items toward that. So better access to the data and better data sharing between all the partners.
Thank you. Senator Moran?
Oh, thank you. I think that, well, most of my conversation you've heard centers around our young people. And I'm one of their biggest advocates because I think that it's very, very important for us to understand that our children are our future. And I think when we look for partners, we should be looking at CCSD. We should be looking at all of private, every educational school or community, the universities. We should have them all as partners because this is an epidemic. It is not something that we should be taking lightly. This is very, very important for our society as a whole. So if I had my druthers, that's where I would be centering my attention to. Every educational community in the state of Nevada.
So just to kind of touch on that, I absolutely agree. Like being able to educate the public is a huge part of prevention. My idea of educating them is a little bit different. Not that I don't agree, because I absolutely do. But being able to educate people who intend to use substances or are going to be around people who they believe are going to use substances on the options of how they can test, how they can know how to keep themselves safe. The fact that there are so many different testing options out there, you can know exactly what you're taking with certain testing products, and being able to then make informed decisions about what you're using or potentially choosing not to use. Choosing to then take that information and go, I'm never buying from that person again because they sold me something I didn't want. And then also being able to have really good, robust education about what an overdose really does look like, how to be preventing that. The fact that there are options, there's nasal naloxone, but there's also injectable naloxone. And that while scary because it's attached to a syringe, is just as effective and in some ways easier to use. You don't have to worry about being able to get their body into a certain position to be able to use it. You just have to be able to hit a nice large muscle group like their thigh. And that is also something that potentially could be placed in naloxone boxes as well to be available to people, and would be potentially possible to do at a much larger scale because it's a lot cheaper than the nasal stuff. I think being able to educate people about those kinds of things, whether they use or just expect to potentially be around someone who does, would be so impactful to being able to continue to prevent overdoses from happening.
Thank you. Vicki, any final thoughts?
Yeah, so I think prevention is a cascade. So I think if we were to support, just as Assemblywoman Thomas mentioned, CBOs that provide primary prevention services to family and youth, so that we can prevent youth from developing substance use disorder to begin with, all the way down to CAT's end of the cascade, people who use drugs who may not be ready to link to care, but we want to prevent them from dying, right? I think as far as who we need at the table, anyone that wants to be, but definitely making it easier for people with peers and people with who've used in the past to be at the table to help us make this difference is extremely important.
I agree with that. Thank you. I think I'd like to add to that discussion. I think to move forward, one of the opportunities we have, we can look to lessons learned across other public health arenas like HIV prevention and our national response to that. We can look for ways, we've talked about this on this panel today, we can look for ways to address stigma, prevention, to increase awareness and education at all levels. Primary prevention all the way down. I think we need to engage more advocates, look at our treatment systems and make sure they're matching what the need is, and then ensure adequate funding. That's always, the most important, right? We have to ensure adequate funding to best resource our work. I want to thank each of you for participating today and sharing your unique insights. And now we'd like to open it up for questions. She's coming with the microphone down front.
I appreciated all your ideas. The obvious thing that you didn't talk about enough is how to resolve the concerns of a practitioner who writes for a chronic pain medicine, for instance, and the threat, the very real threat of the medical board being able to say, you prescribe so many things, therefore your license is at risk. I'm not going to use the word 5 violations and you just lost your license, but that was a real thing that happened. So you have literal practitioners who stopped writing pain medicine, period, because they couldn't do it. So my hardware salesman who said, my wife had cancer and the doctor wouldn't write her any more medicine, but I know where to find it. And so he did. And it was at the corner, not the corner drugstore. So we have a challenge in the medical profession being able to treat patients with what they need who still have fear of reprisals. And I don't know the answer to that, but bottom line, it's very real. Thank you.
Thank you, Dr. Hardy. Do you have any other panel members? Thoughts on that?
Yeah, I do. I agree as well. And I would say that, initially programs such as the prescription drug monitoring program were to look both for people who were doctor shopping and look for these, pain clinics where they were just pushing out the drugs without even having an assessment done on the patients that came in. So I think we're way past that. I don't know if some changes need to be made in the prescription drug monitoring program, but I know when that all came about, we had numerous patients come forward and speak to just what Dr. Hardy laid out is, they'd go and the pharmacy would say, they'd get the prescription, but they couldn't even get it filled and have to go to pharmacy after pharmacy. So maybe it's a need to look at the prescription drug monitoring program and the different pinpoints they have in there for addressing this.
Thank you. Any other questions? Okay. Well, thank you again, and thank you all for sticking around and listening. We appreciate you all.
thank you, panel members, Assemblywoman Thomas, Dr. Kearns, Kat, Virginia, and Virginia. So I just want to thank you for being here with us. Again, those two conditions, congenital syphilis and the overdose deaths, both are what we could call social conditions. The solution to that is beyond public health organizations or healthcare organizations. There are a lot of social issues that contribute to that. Housing is one of them, homelessness, poverty, many other issues that are affecting our communities. And that is why the solution of those problems require a strong collaboration among community members and also a strong intervention from local and state and federal government in order to improve some of those conditions that segments of our population suffer as well. I really want to acknowledge the contribution of the panelists and also our EPI team and for the contribution today. And I really want to thank you, and I really want to say that all members of our team are very proud of the strong collaboration that we have with each one of your organizations and how much we love the work that we are doing, and also the many things that we will be able to do, with your assistance. The health district is engaged in a lot of projects, and especially now that we are entering the post-pandemic period, where we are really recovering from that impact. Our team is trying to reorganize our work. We are also identifying priorities, and these two issues that we discussed today are among our highest priorities. I would say congenital syphilis, we actually, without any additional funding, we decided to start a project with addressing that issue. So we assign a nurse, and then we also incorporate community health workers to participate in that intervention. And today we are seeing just some of the results of that work. In terms of the addressing the opioid pandemic, we have a very strong team in our EPI disease control division, but also we are developing a strong collaboration with different groups.
I don't know if mine's.
Okay. Different groups across the state and also other jurisdictions. So again, I really want to thank you for being here. I know that you guys are very busy, so just by seeing you here, it means a lot to us. And we really want to keep this collaboration. And again, we'd love to see you around. Thank you.